Hello, everyone. We're ready for a CCO Club webinar number 73. That means we're almost at 75. Can you believe that? Do you remember how many of you were here when we had the very first club webinar, this new format that we started? I was there, of course. This is where we take our club questions and run with them, kind of unpack them and answer what our club members want more information on. They come directly from our club members, and they're usually most excellent. So the subject that had come in recently was we want more risk adjustment and HCC coding information. We've been kind of lax on that lately because there's been so many awesome questions coming in, and trying to, I guess we would say, be diverse, because as you know, if some of you have been on the with us for a while, you know I always gravitate towards ICD diagnosis, stuff like that. So been trying to shake it up and not always just grab those first, even though, that's what I want. And risk adjustment, so much fun. I really enjoyed working with risk adjustment and the HCC codes. So I took this question and said, let's continue taking specific specialties and kind of breaking them down, giving information about the top 5-10 diagnoses that are commonly seen in these specialties. Well, the reason I picked pulmonary was because a person that I went to school with just became a nurse practitioner and has decided to go and work at the pulmonary office here locally, one of the pulmonary specialists. So I thought, how perfect is that, right? You know how I'm always bringing things back around to somebody I know or in the family. That means pulmonary is the specialty we're going to talk about and kind of unpack the different diagnoses that are common. Now, we're not going to talk about all of them because there's much more than the ones we're going to go over, but these are going to be the big ones that you see more often, and it isn't necessarily ones that carry a higher HCC or RAF score either for your providers, although, some of them will be pretty hefty HCC scores. Don't forget, for our club members, this is going to eventually turn into CEUs. And as a club member, you're going to have that free access to the CEUs. We like to divide those up instead of giving you one at a time, but make them 5, 10 at a time, and make them also pertinent together. So maybe we'll do a conglomerate of HCC specialty risk adjustment codes or information, or maybe we'll do the E&M changes. Well, we've already done that one. You can go in the club and check those out. If you are part of the CCO Club, you get the support for the webinars, you get the CEUs, but you also get to ask questions. And this is exactly where we get the questions for the club webinar. We also have a student webinar, a little bit different, extended product support. And as I love to say, it's at cco.us/club. Just, I don't know, I like doing that. Oh, so let's start here. And I see something that I left on there. So let me just exit out of this real quick, and let me just get rid of that now, because if I don't, that'll stay on there and bug the rest of us, right? So we were on slide 4. Let's talk about just a review of what risk adjustment is. And if you're joining us and risk adjustment is new to you, then I encourage you to go look at the other education that we have provided in the club for risk adjustment, as well as reach out and check our YouTube channel, where a lot of videos from current and past can better explain. We're just going to do a quick overview. What is risk adjustment? Why do we have to do it? What's being looked at? And that is that risk adjustment is going to allow the payer to compare how much it's going to cost to take care of their population for, say, their MA plan. So UHS has one, Humana has an MA plan, and what they're going to do is they're going to say, we have X amount of people in our plan, and we need to know what's the burden or the cost that it's going to take for us to maintain their health or improve their health. That's the goal. We don't want them getting sicker, but if we can't improve their health, let's make sure that we maintain their health. Thus, they're going to take the diagnoses that are chronic, and those will have HCC scores or category scores that will allow them to do some really awesome math and predict what it will cost to take care of that patient who has COPD, for example, or has emphysema. That's also based on if the patient is male or female, because surprisingly it is different. And they also look at the patient's age. Now, there's some things that some different types of formulas where they look at where the patient lives. For example, if a patient lives in New York, it's going to cost more to take care of them if they live in the rurals of the Midwest. But that is all included in the demographics. And these scores go across the board pretty much. They're standard demographics. Are you male or female? How old are you? And then what chronic conditions do you have? Because it takes more money to have the funds set aside for a 65-year-old male versus who has diabetes, for example, than an 85-year-old male who has diabetes. And the same way is it will cost differently for a 65-year-old female with COPD and an 85-year-old female with COPD, right? So the disease and the demographics is all included. We're not going to go into the formulas. We've already done education on RAF scores and how they're determined. And if also this is something that you're watching because you're curious about risk adjustment, know that we're just skimming the top here. What you're going to need to know is there's meat involved. Well, how do we determine meat? It is monitor, evaluate, assess, and treat. When we monitor a patient, what do? We're looking at our patient that has asthma, and we're seeing, does this patient respond to this medication? How many times does the patient have to use their rescue inhaler in a week? Is seasonal allergies involved in their care? If they don't have a problem with seasonal allergies in their asthma, that's great. Maybe it's exacerbated by athletic type activity. They go out and they decided to take up an aerobicize class. Do they even have aerobicize anymore? I don't know. I don't think they do. They probably do, but they call it something else. We had aerobicize, then we had jazzercise, and now we have Zumba, right? So again, maybe they took up a class to lose weight and it exacerbated their asthma. Also, maybe it is something where they need to lose a little bit of weight, right? So this is the ABCD of what we have to do for our patient to show that yes, they have a chronic condition, but it's an active chronic condition. So we have documentation that shows we're monitoring their asthma, we're evaluating it, how is it doing now compared to in the fall, in the winter, in the summer, just as one way to evaluate it. We're assessing them, doing a physical exam, listening to their lungs, and we're treating them. Maybe we're prescribing a rescue inhaler. Maybe they're going to take treatments that they can do at home. Maybe we need to send them off to a pulmonologist and do more intensive study, or maybe we need to send them to an allergist to see if allergies are triggering the asthma that might not have been happening in the past. So meat is very, very important. Now we're going to jump in to one of the most common codes and diagnoses that you see that relate to the respiratory system, and that's COPD. Very common chronic condition. And I didn't write out what COPD stands for, but it's chronic obstructive pulmonary disease. The basic code for COPD is J44.9. That's COPD unspecified. Most of the time we'll say, well, we really don't want to have an unspecified code. The fact is there isn't that much higher specificity with COPD. You either have it or you don't. However, they can have acute conditions that exacerbate COPD. And those are, the first one is J44.0, which is COPD with, and that C with a line, backslash C means with. If you see backslash S, that means without. So COPD with acute lower respiratory infection. Whenever you have a type of infection, just as a general rule with coding, you're going to want to also identify what the organism is if you know it. Now, if this is an initial treatment or an initial visit, you may not know what that is, especially if it's an acute. However, if they come back for follow-up, or you can get the results like a rapid stress test or that type of thing, then again, you would put what the organism is. However, J44.0 is an acute lower respiratory infection. So what's the difference between a lower respiratory infection and an upper respiratory infection? It's locational. We have in the lower lobes of the lungs, and we have an image here of the lungs. That's where the irritating part, that's where all of the irritation is happening. Whereas if you have an upper respiratory infection, that's the throat and the trachea all up high, right? Now, upper respiratory infection doesn't risk adjust. Lower respiratory infection does. Why do you think that is? Because lower respiratory infections turn into pneumonia if not treated. Now, again, it doesn't have to, but as a general rule, right? That is something that you got to be cautious of. We've got lower respiratory infection, irritation, thus more fluid building up in the lower part of the lungs. Then that's very specific, right? Lower respiratory infection, acute. J44.1 is COPD with acute exacerbation. Now, how is that different from J44.0? J44.0 is locational, lower respiratory infection, whereas COPD with acute exacerbation means we have COPD, however, we're really struggling with it right now. We're having trouble breathing. It's not identified as, there's not a lower respiratory infection, there's not an upper respiratory infection. It's just more complicated right now. J44.0, lower respiratory infection. J44.1, acute exacerbation. And if the patient has COPD, but nothing else is happening at that time, just good old plain old fashioned COPD, J44.9. Always remember, when you're dealing with a J44 code, that if there is asthma on top of it, you're going to code that in addition, right? Now, COPD, under the umbrella of COPD, asthma falls underneath that, as well as emphysema. However, asthma doesn't risk adjust the same as the lower respiratory infection. Also note that, can a person have J44.0 and J44.1? Yes, they actually can. I'm not going to talk too much here about the different parts of how chronic bronchitis works and stuff. I think that we've done that often in some previous videos. Let's talk about chronic bronchitis. Does chronic bronchitis fall under the COPD umbrella? Yeah, it does. It's a J code. So let's look at these three major J codes. We have J41.0, simple chronic bronchitis. We have J41.1, mucopurulent chronic bronchitis, and then unspecified chronic bronchitis, J42. If we don't know what type of chronic bronchitis the patient has, J42 is the code that we're going to go to. So what are the signs and symptoms for J41.0? Productive cough, meaning we're coughing up sputum, increased sputum, and no airway obstruction. Because if we have airway obstruction, then we're looking more like a COPD type thing, right? Because that's chronic obstructive disease. J41.1, what does that mean? It's mucopurulent. Now, if you don't know what muco is, mucus, and that's what we have, mucus all over our body inside there. It just makes things more slick, right? We have a type of fluid that is around our muscles so that we don't build up friction. Have you ever seen anybody working, if you haven't seen it in person or if you've seen it on TV, and they're grinding on metal or doing some type of work that's repetitive, and then you see somebody that has a hose and they're pouring water on top of that? And you think, what in the world are they doing with that water hose? What they're doing is they're trying to prevent whatever the friction is doing, preventing the friction from heating up whatever's being worked on. So this happens with water or metal. They'll use water. Sometimes they actually use oil on things, right? If I'm trying to think, I've got on the tip of my brain an example that I was thinking of, but now I'm starting to lose it. If you can think of some type of like heavy equipment, or anytime you've seen them pouring oil or water while that rapid movement is happening, let us know in the chat. I remember the first time I saw something like that, and I asked my husband, I said, what are they doing? Aren't they making a mess with that water hose? And he was explaining to me they're trying to prevent a fire or friction. Maybe if you remember starting a fire with sticks, you learn how to rub those sticks together, right? And then you get a little bit of heat and smoke, and then it literally will catch on fire. It doesn't make a spark. There's other ways to make a spark and start fire, which again is type of friction, but this is heat related. Now, if the wood was wet or you drop oil or something on there, then of course it's not going to cause that heat and friction, and therefore, so that's what mucus does. Purulent means pus. Whenever you see that word, a lot of times with ear infections, you'll see the code for purulent, right? So sputum has pus in it. That's different. That's purulent. And there's a secondary infection, or secondary to infection. So we have some other type of infection happening in the lungs, right? We're producing sputum, and that infection is in the sputum. Unspecified J42. So a healthy bronchial passage has plenty of airway and room and stretchy, but if we have irritation, simple chronic bronchitis, then that passage swells up. That's what bronchitis does. And then it will also produce mucus because it's irritated and causes friction. So J41.0, J41.1, and J42 often used for chronic bronchitis HCCs. Oh, when cutting tile, that's a good one, Nancy. You're right. In fact, that may have been what I was looking at, because my husband was a plumber for many, many years. Emphysema. there's a kind of a pathway in the disease process for emphysema. Emphysema falls under that window, that umbrella that I told you about. However, emphysema ends up being like the end result. Emphysema is damage and structural change to the lung itself. Person can start out with asthma and it be chronic and it gets worse and worse, and then they end up with COPD, and then it gets worse and worse, and then through time, age, irritation, it eventually turns into emphysema. So part of the lung that's affected if a person has panlobular emphysema, it's destruction of the acneus. Now that is these, if you see these little alveoli, that is where the alveoli is opened up. Okay, that's what that's called. And then if you have central lobular emphysema, that would be J43.2. That's dilation and destruction of the bronchioles. So look up the acneus and the bronchioles, two separate areas that there is destruction. Remember, anatomical change, the change to the structure of the lung. That's when you get emphysema, and you don't get that transfer, good transfer of oxygen, and that all happens right there in the alveoli. The cellular transfer or the osmosis can't work if that membrane is not soft, wet, malleable. If it is broken up and kind of stenotic or stenosis around there, hardens, then we're going to have either J43.1 panlobular emphysema or J43.2 centralobular emphysema. Remember what other means with codes? Often if we use other, that's an 8. Not 100% of the time, but 99.5% of the time, maybe 95.6. Yeah. Whenever you see a 0.8 or an 8 at the end of the code, you're probably looking at other. And other indicates that there is a name or a diagnosis. There's specificity there. However, there's not a code assigned to that specificity at this time. I can't think of one particularly off the top of my head that doesn't fall in these categories, but let's say we make one up. So we say type A emphysema. Well, the provider states the patient has type A emphysema, and you look and it doesn't fit anywhere in the list of types of emphysema, so therefore that would be other, J43.8. 8's kind of a magic number that means other. J43.9, 9s are 99.7.421 times unspecified. Now, there are times when 0.9 ends up being other and 8 means something else, but not very often. If you see a 9 at the end of your code, that last character, it's usually unspecified. So unspecified emphysema means it just states emphysema and we have no other information. We don't know that it's panlobular or centralobular or other. It's just emphysema. This can happen with new diagnoses of emphysema, and we need to send them to a pulmonologist to get a higher specificity, or more testing needs to be done, and then we'll get a diagnosis at a higher specificity. Again, that's where you start getting into the specialty. The specialist is going to be able to document what the test results are, therefore giving the higher specificity, and you want that to carry over on the patient's care and documentation for every encounter going forward, like their problem list. Note, for risk adjustment, every year, January 1st, the slate's wiped clean. So if you have a diagnosis of a patient that has panlobular emphysema all year long, and they're being treated successfully and they're not having a lot of exacerbation, they're doing fairly well considering, on January 1st, guess what? They don't even have emphysema anymore as far as CMS is concerned. They have to go to the provider and have the documentation done again that says that they have emphysema. And we know that the patient last year had panlobular emphysema. But if the provider states that the patient has emphysema and does not give that specificity, then again, the slate's wiped clean. Then we're losing that higher specificity for the RAF score on the HCCs. Every year, January 1st, we got to make sure that documentation's clear and specified. Bronchiectasis. Now, this is a little bit, it's more unique in that you may not see it as often. I don't see it as often, but that just may mean that I don't pull charts as often with people that have pulmonary conditions. You can also, with this condition, have acute lower respiratory infection. You can have acute exacerbation and be uncomplicated. So with an acute lower respiratory infection, which is called LRI, by the way, is J47.0. If we have an acute exacerbation, J47.1, and of course that 9 for J47.9, uncomplicated. Note, uncomplicated is not the same as unspecified. Big difference there. Remember, I told you that it was 99.7.421 or something like that. Well, here's a time where it ends in 9 and it's not unspecified. If it was unspecified, that means we have no further information, right? But uncomplicated, that's specificity. So what is this condition? What happens with the normal airway? It's nice and smooth in the passages in the lung, but when we have bronchiectasis, we have a widened airway, so it's kind of like stretched out elastic, and there's a little bit of elasticity to these passages, just like arteries have that elasticity. Probably this has more stretch to it. And then it gets scar tissue involved. The walls get thickened. So think of when a person has cardiomyopathy and the heart starts getting thicker and thicker and thicker because it's a muscle. This is not muscle tissue, so it's not being worked out and thickened that way. However, it's tissue that is being thickened because of scar tissue and repetitive irritations. If you take your hand and you rub and rub and rub and rub and rub and rub, what's going to happen? You're going to eventually cause a friction spot, right? Well, that'll finally heal up, and then it may not leave a scar. But once that heals up and the scab falls off and stuff, and you sit there and you do that again, and the whole that kind of actually warmed my finger up just doing that. You do it again and again. Eventually, that's going to toughen up, right? And that skin is not going to have the turgor in it that your skin normally would. That's what's happening here. That irritation is building, that constant irritation. And on top of that, we have mucus, because whenever we have irritation or anything going on in the respiratory system that needs to have elasticity and fluid and movement, because our lungs never stop, then we have mucus built up. So all of those combined gives us this condition, J47. Chronic respiratory failure. Now, chronic respiratory failure is something that you might not see in the office, the outpatient office, very often, right? Because this is something that's going to end up, you're going to be at the ER, you've got serious problems. Chronic respiratory failure with hypoxia, J96.11. Hypoxia just means we have too much CO2 in our bloodstream. So we have the oxygen and we have CO2 in there as well. But when the oxygen level decreases and the CO2 goes up, it turns into hypoxia. That's what that's called. And you just can't breathe. Your body will start shutting down. because CO2 doesn't do anything for the body. It's a gas that we want to get rid of, whereas oxygen is what keeps the body going, is the fuel for the body. Well, I wouldn't call it the fuel for the body. That would be probably something else, sugar and stuff. Okay, so if you've ever seen people that do scuba diving, right? I think when they just use the snorkel, right, they're just breathing regular air. They just go up to the top and they've got that tube and they're getting some air, and then they can go swim around and they can still stay under the water, but that tube is giving them outside air. If you see somebody that has the big tank on their back that looks like a fire, not a fire hydrant, what am I trying to think of? Fire extinguisher, right? Then that's that particular tank is going to let you breathe in the oxygen and you expel out into the water the CO2. That's what all the bubbles are, okay? And so you're not building up CO2 in your lungs. If you see someone under the water and they don't have that big old tank on their back, but they have something that looks like a backpack or a more squared, compact thing like a briefcase, but kind of looks like a hard backpack, that's different. That's called a rebreather. And what it does is that you don't, there's no bubbles involved, and you can stay under. I don't know that you could stay under longer, but you don't have to, you don't run out of air at the same rate. When you're expelling the CO2, once that tank is empty of oxygen, there's nothing left. However, with this rebreather, what it does is it has the oxygen in it, and then you breathe it out and it recycles what you breathe out, because CO2 still has O2 in it because it's CO2, right? So it filters and then gives you oxygen again, right, from the CO2. It breaks it down. And so it's a recycling your air. The downside of that is that you get this hypoxic feeling, right? That your the C part of the CO2 is not expelled, and therefore it's in your system at a little higher level. Now you're able to breathe that. Room air, regular room air is not 100% oxygen. But again, your body doesn't like it. It likes this air or that oxygen they feed you, when you start building up the CO2 in your body, it gets panicked. And you have to learn. The people that do that are usually, special divers. They have to stay underwater for a longer amount of time, or they don't want anybody knowing where they're at. So they don't want bubbles and things. They're being very secretive, special ops type stuff. Actually, the way I learned that was from a special ops person. And that is a hypoxia feeling, that your CO2 is too high in the body. J96.11. Chronic respiratory failure and with hypercapnia. Now that's different. J96.12. Hypercapnia is not the same as hypoxia. Then we have chronic respiratory failure, unspecified whether hypoxia or hypercapnia, J96.10. Now, this is an unspecified. Notice there isn't a 9 there. What they need to do is they'll be running blood tests and things like that to determine, is it hypoxia or is it hypercapnia, meaning we have too much of this in our system. Note also, whenever you have a person that's going through respiratory failure, they're probably intubated. They could be intubated with a tracheostomy. And if they are they need a status code for the tracheotomy status, that would be Z9 3.0. That risk adjusts because that takes a lot of additional care. Or the patient could be at a lung transplant status, which is Z9 4.2. Two status codes that could be applicable for this patient, which these ECOs carry a risk adjustment. Just looking at the time, we are doing really, really good with our time. Cystic fibrosis, CF. The codes, we have 4 main codes that we're going to talk about. With E84.0, that's CF with pulmonary manifestations. So not cystic fibrosis in itself is a disease. It builds up it loses the elasticity, and too much mucus and stuff fills up in the lungs. If you have CF and pulmonary manifestations, we want to know, what's the manifestation going to be? Maybe we have an infection. And if we do, then what is the infection? It could be Pseudomonas, for example. That's the one that they gave here, B96.5. Anytime you have an infection or something else going on like that, especially with the respiratory system, they're going to want to know, by the way, if you have that information, we need that because we need it for statistical purposes. The B96.5, that doesn't risk adjust. However, remember, we code for statistical purposes. It just happens to be a convenient way to get paid. We need to know if this patient, our CF patients, how many of them have this difficulty with contracting Pseudomonas. E84.1. Now, whenever you see a lower dash like that, then you know that means there's more characters involved. Cystic fibrosis with intestinal manifestations. And you think, wait a minute, I thought CF was the lungs. It is with the lungs. However, there is other things that can happen that can irritate the lungs. Let's look at the example here. The first one, E84.11, meconium ileus with cystic fibrosis. Does any of you know what meconium is? I'll give you just a second. We'll come back to that. E84.19, we have CF with other intestinal manifestations like distal intestinal obstruction syndrome. Note here, one of those exceptions to the rule. There's always exceptions to the rule. Other, instead of it ending in an 8, this one ends in a 9. Right? Not 100% of the time is an 8 going to be other and 9 going to be unspecified. These are exceptions. Anybody know what the meconium was? Well, think about obstetrics. Do any of you have experience with obstetrics? When you deliver the baby, if there is something that's kind of green in there, they maybe, yeah, there you go. Marcia says, or is that Marcia? I don't have my glasses on. It says baby's first poop. Yep. In utero, if they have a bowel movement, that's called meconium. And if it's fine, that's pretty common to have happen, but there's side effects. The baby's not breathing, so we don't worry about it like necessarily being in the lungs. However, when the baby comes out, if they don't get that all cleaned out, they could aspirate that. So meconium is not what we want in the lungs. So E84.11, that's what it means. We got poop in the lungs. And when the patient has cystic fibrosis, that's going to cause complications. E84.8, we have CF with other manifestations. There's that 8. So it wasn't applicable for E84.19 other, but E84.8, the character is in a different spot. That's other manifestations. And then they say, well, let us know. You got to have an additional code. These additional codes won't probably risk adjust, but what is that other manifestation? They gave examples of nasal polyposis, pancreatitis, and cirrhosis. They can have cystic fibrosis as well as cirrhosis. E84.9, there's your unspecified cystic fibrosis. So just plain cystic fibrosis, no other information, E84.9. This is just about going to wrap us up, guys. Chronic pulmonary embolism. We know that if a person has an embolism, that's an emergency. If you have a embolism that goes to the lungs, that can kill you very, very quickly. But a chronic pulmonary embolism, that means the person's living with that embolism right there all the time. It's just not going anywhere, but it's causing complications. That would be I27.82. Note the first character. We are no longer in a J code. J codes have to do with the respiratory system. I think if some of you have been on any of our other videos or watched, you probably know I like to think of J code as that little device that you measure from the corner of your mouth to your ear in an emergency setting. And it looks kind of like a 5, and it's plastic, and you stick it in the mouth and then you turn it, and that part that's curved will hold the tongue up. So it allows you to have a patent airway. That's how I think of a J codes, lungs, patent airway, and that little device I got to learn when I learned how to be an EMT. Now, other people have said, excellent, a fish hook. It looks like a J, and fish can't breathe out of water. I thought that was an excellent one too. So all these codes we've been talking about were J codes, very applicable to that. And this one, however, is an I code. What's up with that? I27.I2 or 82. Shoot, said it wrong. Chronic pulmonary, so we're in the lungs, embolism. Embolism's caused by blood. What does the I codes? They're all ischemic codes. They have to do with the heart. So we have a clot that has to do with blood. This is a direct result of, coming off of the heart. That's why it's dealing with the lungs. However, it's an I code. I27.82. If you use this code, there is a chance, very high chance, that your patient is on some type of anticoagulant therapy, and that would be Z79.01, long-term use of anticoagulants. Now, that doesn't risk adjust. However, it is something you want to be aware of, that you capture all of these codes. Notice almost all the codes that we've talked about tonight have had additional codes that are applicable to tell the rest of the story. That does not mean they risk adjust, but as a general rule for the coding guidelines, we need to code all of those codes in addition. They're applicable to this code. All right. I think I'm trying to remember, but I think that was, no, we got pulmonary hypertension. I kept thinking, no, we're getting to the end. Good old pulmonary hypertension. Very unique, and also another I code. Pulmonary hypertension is not the same as hypertension, not like I-10. In fact, it's really different, besides the fact that it's affecting the lungs. I27.0 is your primary pulmonary hypertension. That's going to be your most basic type of hypertension. Secondary, I27.21, which would be easy to think of because the 2 means secondary. Secondary pulmonary arterial hypertension. Then we have the I27.22, the PH due to left heart disease. I27.23 is PH occurring secondary to lung disease and or hypoxia. I27.24, chronic thromboembolic hypertension. I27.29, other secondary pulmonary hypertension, and I27.20, unspecified pulmonary hypertension. And there you go. It ends in a 0 and it's unspecified. And other ends in a 9. Here I tell you that the most common 9 is unspecified and 8's other, and then I'm showing all these exceptions to the rules. Let's talk about what pulmonary hypertension is. It's not the same as high blood pressure, hypertension. What's going on is that the vessels, the blood vessels in the lung are being constricted, and that's what hypertension ends up being. We have high blood pressure, meaning your heart is struggling to get the blood pumped through the body. Why? Maybe it's because the patient is obese and the vessels are constricted. Maybe the patient has other types of conditions that, for whatever reason, that are causing that tightness of the vessels. Maybe it's secondary to something else. The patient takes medication and they get hypertension. Ultimately, in this graphic, you can see the normal one. See how the vessels going through the lung are nice and open and big. And then look at the second one. The lung on the one side has nice big vessels, but on the other side, they're compressed, they're tiny, they're spindly, they're thready, they're not look big and healthy. Therefore, there's pressure. And as a result, notice the pooling of the blood in the heart. Okay, the deoxygenated blood is not it. There's more. We're getting like a pooling sensation, like the creek has got debris, and you've got flash flooding in your heart due to the constriction of your lungs. Therefore, that makes sense when you say primary versus secondary. Primary pulmonary hypertension, there's just something wrong with the vessels. Secondary arterial hypertension, that means the arteries are constricted and working really hard, but it's secondary to something else. Then we have due to left heart disease, the left side of the heart, which is very specific, versus the right side of the heart. And I won't go into that too much because I really enjoy that and I will go off on a tangent. But the pulmonary hypertension is caused to disease to the left side of the heart. And then secondary to lung disease and or hypoxia, maybe the patient has COPD and developed pulmonary hypertension secondary to the COPD or emphysema. Tell us what the underlying condition is. The examples that they give is polycythemia vera, essential thrombocytopenia, and sarcoidosis, which is like I think of that as those passages turning into trees, kind of getting petrified. Let's wrap it up with another condition that can exacerbate lung conditions. And you want to make sure that these are always captured, that your provider is getting, not only is it for MIPS and things like that, but your BMI and the morbid obesity. Now, obesity is different than morbid obesity. Morbid obesity is anything over 40, risk adjusts. If you have a BMI over 40. So the documentation tips to always remember is that you can't have a BMI alone and have it risk adjust. You have to have obesity noted as well. And it has to have weight-related diagnosis to qualify for risk adjustment. So just the BMI by itself doesn't work. And now they're pretty trained to get the BMI in there. We don't want it to contradict itself either. So there's an example that this is a really good one. If you have a BMI of 30 that's documented with weight-related diagnosis of morbid obesity, it's actually obesity, because you have to have a BMI of over 40 to be morbid obesity. And this is something that will lose you on your risk adjustment scores if you don't get that right for your providers, and they will lose money. Any questions? Any questions coming in now? So while you're looking for questions, then let's remind you that you can get answers to those questions. If you don't think of them tonight, you think of them later on the CCO Club, and that's cco.us/club. If you want to join the CCO Club, super easy. I think it's like less than $20 a month, and you can stop anytime, but you have access to all of this cool, all these cool things. And you can join at any time, you can stop at any time, and you will have access to me, the other instructors, the coaches, our students are in there, lots of subject matter experts. And it's a fun place to as Lorraine says, to kibitz. All right. I'm not seeing any other questions coming through, so make sure that if you have a great topic that you share it in the forum. Oh, one question came through. It says not a BMI, not sure what that means. Body mass index. Body mass index is the BMI. All right. BMI of 35. Ooh, what is a BMI of 35? So BMIs are based on, we did a video on that. You can go find it on our YouTube channel, Medical Coding Cert. But a BMI of, a normal BMI is in the 30s or the low 20s. And then once you get into the 30s, then you're obese. And then once you get past 40, it's morbid obesity. You can have comorbidities, yes. Comorbidities to all of these conditions. All right. It was a great, great topic anytime we talk about risk adjustment. See you next time.